Welcome to this explainer. Today, we're diving straight into the paradigm-shifting updates from the 2026 KDIGO guidelines for acute kidney injury and acute kidney disease. Now, if you're a clinical professional, you already know just how incredibly challenging it can be to stay ahead of acute kidney decline. But with this new public review draft, well, our global standards are getting a massive, precision-based upgrade.
Okay, let's just get right into it. Historically, our total reliance on serum creatinine has meant we were essentially looking in the rearview mirror. We were chasing trailing indicators of kidney damage rather than actually predicting it. The guidelines point out that by the time we actually see a significant bump in serum creatinine, the cellular injury, it's already happened. In fact, you can literally lose up to 50% of your kidney function before creatinine even budges. We've been reacting to the aftermath instead of intercepting the injury.
And that brings us to the absolute core of the 2026 update. We're finally moving from a purely functional diagnosis to a dual functional and structural approach. That's huge. We're no longer just staring at traditional markers like creatinine and urine output. We are now officially bringing in structural criteria. This means using biomarkers that reflect cellular stress, damage, or inflammation, way before the kidney's actual filtration function starts dropping.
So here's our clinical roadmap for today's explainer. First, the new AKI definition. Second, updated AKI severity staging. Third, defining acute kidney disease. Fourth, biomarkers and risk stratification. And finally, post-AKI follow-up care. Let's get to it.
Section 1. The new AKI definition. Let's start with this diagnostic overhaul and exactly what these new criteria look like.
What's really fascinating here is the addition of cystatin C and structural damage biomarkers, right alongside our usual creatinine and urine output markers. Cystatin C is a total game changer because, unlike creatinine, it isn't tricked by a patient's muscle mass. The guidelines now strongly suggest using it when creatinine might be, less than accurate. Plus, if you detect an elevation in a validated kidney damage biomarker, that alone now fulfills the structural criteria for an AKI diagnosis. No waiting required.
But here's a crucial detail. It is absolutely essential to remember that AKI is defined by these functional or structural abnormalities happening within a really firm 7-day window. Whether it's a 0.3 milligram per deciliter rise in creatinine over 48 hours or a spike in a damage biomarker, that 7-day time frame is the strict anchor for defining the acute injury event.
Moving on to Section 2, updated AKI severity staging. So once we've identified the injury using these new 2026 standards, how exactly do we grade it?
This is where the brilliantly modular CUB system comes in. It basically lets you mix and match creatinine, urine, and biomarker levels to get a highly precise severity stage. You know how urine output and creatinine constantly disagree in the ICU? Well, KDIGO finally decoupled them. Now you stage the patient with a C score of 1 to 3 for creatinine, a U score of 1 to 3 for urine, and a B score of 0 or 1, depending on if a damage biomarker is present. It gives us this incredibly nuanced, multidimensional picture of the patient's exact status. We've also got a definitive line in the sand now, a strict 48-hour cutoff. This clearly separates a transient reversal from persistent, much higher risk AKI. If the drop in kidney function bounces back within 48 hours, okay, it's transient. But if it drags on past 48 hours and up to 7 days, it's persistent. And this is so vital because persistent AKI is directly tied to significantly higher rates of chronic kidney disease and mortality down the line.
All right, Section 3, defining acute kidney disease. Let's see how all of this builds into acute kidney disease, or AKD, which has really been the missing link in our continuum of care. The biggest takeaway here is grasping this timeline. AKI covers those first 7 days. AKD acts as the critical bridge up to 3 months, and anything beyond that 3-month mark becomes CKD. Before we had these unified definitions, patients were literally falling through the cracks the second they left that acute 7-day window. AKD formally recognizes that the pathological processes and the risks, they don't just magically vanish after a week. They linger and they require our active attention.
The conceptual framework provided by the guidelines clearly shows how patients transition into AKD even if they never actually met the strict criteria for a prior AKI event. Yeah, you heard that right. A patient can develop AKD without ever having a recognized AKI. For instance, if their GFR just slowly drops over the course of a month, they totally miss that 7-day AKI window, but they are absolutely caught by the 3-month AKD criteria. It's a fantastic safety net to catch smoldering kidney issues before they harden into irreversible chronic kidney disease.
Section 4, Biomarkers and Risk Stratification. Recognizing the injury is great, but obviously preventing it is so much better. And that brings us to risk stratification.
As modern clinicians, the big question we have to ask ourselves is, how can we proactively intercept severe kidney damage before it takes hold? The 2026 guidelines make it crystal clear, simply waiting to react to creatinine spikes is absolutely no longer the gold standard. We've got to assess functional reserve and tubular stress way before the filtration rate collapses.
To do that, the guidelines point us towards specific biomarkers. We're talking NGL for damage, or TIMP2 multiplied by IGFP7 for cellular stress. These help us spot high-risk patients incredibly early. Measuring baseline albuminuria, for example, gives us massive prognostic value across all sorts of clinical settings. And in the ICU? Checking stress biomarkers within the first 12 hours of admission or right after major surgery can trigger targeted, life-saving kidney protective protocols way before the traditional markers even budge. Then there's the furosemide stress test, or FST. This is highlighted as a brilliantly powerful functional assessment. It helps predict exactly which patients might progress to severe stage 3 AKI or end up needing dialysis. By giving this standardized diuretic challenge to euvolemic or hypervolemic patients with early AKI, it's kind of like putting the kidneys on a treadmill. You get to accurately gauge their tubular functional reserve. If they don't produce enough urine after the test, that is a massive red flag for severe progression.
Now, for the folks building out health systems, implementing this requires a rigorously structured pathway. If you're going to launch predictive electronic AKI risk models in your hospital, the guidelines explicitly warn against using standalone interruptive creatinine alerts. Honestly, without a multidisciplinary response protocol backing them up, those standalone alerts just cause massive alert fatigue. Real success means engaging your stakeholders, educating your users, and constantly auditing the outcomes to make sure you're actually improving patient care, rather than just endlessly pinging doctors' phones.
Finally, Section 5. Post-AKI follow-up care. So how do we protect these really vulnerable kidneys after the patient is discharged from acute care?
Well, this 90-day AKD window is incredibly precarious. It leads to all sorts of outcomes, everything from total resolution all the way to end-stage kidney disease or even non-renal cardiovascular events. It's a staggering fact, but survivors of AKI have a shockingly high rate of hospital readmission. Often it's due to heart failure or fluid overload, simply because their carefully balanced home medications were tweaked or completely stopped while they were in the hospital.
To fight back against these risks, the guidelines introduced the COMPS framework. It's a straightforward, really holistic checklist to ensure safe post-discharge transitions. It stands for kidney function checks, advocacy and education for the patient, medication review, pressure, which means evaluating blood pressure and volume, and finally, sick day protocols. That way patients know exactly what to do with their meds if they get dehydrated at home. It's just a wonderfully simple way to structure outpatient care.
And for patients who specifically require outpatient dialysis following an AKI, we have the comprehensive Watch Me protocol. This guides every single facet of their ongoing recovery care. These patients are highly vulnerable, but their kidney function might actually be recovering. So we have to constantly monitor their dry weight, protect their dialysis access, avoid toxins, track their native clearance to see if we can stop dialysis, manage hemodynamics, reconcile medications, and provide continuous education. It covers the whole shebang. By taking clinical data and plugging it into a validated 6-variable risk score, we can precision target our nephrology resources. We can focus on the patients mathematically most likely to progress to severe CKD. By looking at factors like age, sex, baseline creatinine, albuminuria, AKI stage, and their discharge creatinine, we can calculate exactly who needs intense nephrology follow-up and who can be safely managed by their primary care provider.
So, as we wrap up this explainer, I want to leave you with one absolutely vital question. Are your clinical workflows ready for the new standard of precision nephrology? These KDIGO 2026 updates challenge us to look way beyond simple trailing markers. It's time to embrace structural biomarkers, highly precise staging, and structured follow-ups like CAMPS and Watch Me. Thanks so much for joining me on this deep dive. Now let's get out there and protect those kidneys.